Hello everybody, how are you doing today? Today we're going to talk about bleeding disorders. This is one of the biggest topics I think students need to get a good grasp on. If you ever shadowed a hematologist, you gotta wonder, how do you remember this stuff, man? This is crazy, man. I can keep it straight. Yeah, that's true. Because they got a trick, man, and they never tell you. And I still have to give credit to Dr. Barone because he taught us this for medical boards. I want you to first of all split your brain into two. Okay? Into two. So you can understand what bleeding disorder is all about. If you're watching this video right now and you don't understand the clotting cascade and you don't understand the platelet plug cascade, please go back, click down here and go back to the clotting cascade video so you can understand what we're about to talk about right now. So, we're going to split our brain into two. And from now on to forever and ever and ever, it's going to be two brains, okay? On one side of our brain right here, it's going to be platelets. Platelets. Only platelets. On this side of the brain, coagulation factor dysfunction. That's all I want you to know for now. You split your brains into two, platelet problem, clotting factors, coagulation factors. They are two different things. Remember, platelet make the primary hemostatic plug, right? And these guys are gonna make the fibrinogen into fibrin, and everything's gonna come together. So let's start. Patients are gonna come into the hospital and they're gonna tell you they're bleeding, and you're gonna be like, okay, what am I supposed to do now? Yeah, there's something because they think you know the answer. And now we're going to figure out by the end of this lecture. The first thing you have to understand is it a platelet problem? Or are they missing some coagulation factors? We don't know. So they're going to come in with this. On this side of the brain, this is the only part of the brain we are working with right now. Platelets. See? Platelets, coagulation factors. I try to draw a map of the brain. One part for cerebellum and the other part so we can be on the same page. They're going to come with superficial bleeding. That's the history. Doc, I noticed I have this little dots on my skin. They call them petechia. Petechia. Or they might have something called ecchymosis. Or a purpura. From now on till thy kingdom come, anytime you hear purpura, ecchymosis, petechia, always think platelets. Petechia, it's going to be your board. They're going to say, oh, he has some petechia lesion, a palpable purpura. You're like, palpable purpura? Sounds like something like it's done with the platelets. Always remember that. Meningococcemia, sepsis, DIC, we're going to talk about that. Platelets, petechia, ecchymosis. Petechia is tiny little dot hemorrhages you see on the, like under the skin, tiny little dot. If it gets a little wider, it becomes an ecchymosis. It's kind of spread, okay? And purpura, it's more even widespread, okay? Look the picture up on Google and you'll see it. That will give you an idea picture, okay? Because when you see it on a patient, like, oh yeah, I might have a platelet problem. Or they'll say, doc, you know, my nose is bleeding. I have nosebleeds. You don't know if it's a platelet problem. You don't know if it's a coagulation problem. We're about to find out. Or they'll tell you, doc, my menses is ridiculous. I'm bleeding like crazy. Menorrhagia. That's all mucous membrane. Okay? Endothelial bleeding. Skin. Mucus. Skin. Palpable purpura. Ecchymosis. Petechia. Menorrhagia. Nosebleeds. Right? So when they come into your doctor's office, internal medicine, you're like, you know, what do I order first? Since you're thinking platelet, the first order is what? Get a CBC. When you get a CBC, which is a complete blood count, he'll give you the platelet count. You want to know what their platelet count is. Way back in the days, you know how they used to know if you have a platelet problem? We use something called the bleeding time. Do you know what the bleeding time is? It's the time it takes you for you to bleed until you stop. I think that is crazy, right? Like, I'll cut you, let me see how long it takes you for you to bleed. Okay? Actually, it's not cool because the way they test it, they'll take blades, put it on a scale, and they snick your skin and they start to time. Let me see how long it takes you to bleed. I don't think any of you guys will. I'm not sure they're not gonna do that on me for sure. No way. Okay. So when you hear bleeding time, always think a platelet problem. Now we're gonna take our brains, our little big brain, and split it into two. There's two things that can happen. I can actually have low platelets, which your terminology in medicine is called what? Thrombo, right? So we're gonna split this into two now. I can have low platelets, which we call thrombocytopenia. Did you see that? Low platelet. Let's see, what can cause low platelets? A lot of things can cause low platelets, right? But what I want you to know, there's three things in medicine that's always like there. They will test you on your bad boards. You're gonna be like, oh, not again. Is remember these three things. The first one is ITP, idiopathic, which means we don't know what causes it. Thrombocytopenia. 2, TTP, thrombotic thrombocytopenia. I'm not going to talk about the pathogenesis of this disease because that's a whole lecture on its own. And the third one, HUS, hemolytic uremic syndrome. This is a classic 3 thrombocytopenic syndromes you need to come into memory. This is extremely important. But every time you see it, low platelet, so which means if their platelet is low, what you expect the bleeding time to be. If I don't have any platelets, remember the EMFs to come to the spot because they're low, I'm going to be bleeding a lot. I mean, bleeding time will be extremely high. Right? Remember those three things. Keep that into memory for now. Another thing that can also cause low platelets is Heparin induced thrombocytopenia. It's basically you making antibodies against platelets and heparin, which also consumes your platelets, which I'm not really going to go into details because that's another lecture in its own. But remember these 4 things because we're going to talk about their pathology and the pathophysiology later on down the line. However, actually, I might have platelets and they might not be working. Can you believe that? We can actually have normal platelet count. And by the way, what is a normal platelet count? It's between 150 to 400,000 cubic millimeters. Just remember that number. You have to know that eventually, okay? Actually, I can have a normal platelet, but they're not working. How can that be possible? I have platelets, but they're not working. Let's see, how can that happen? A patient on aspirin. How does aspirin work? Let's show you. Remember the arachidonic acid? Aspirin is going to block cyclooxygenase 1 and 2, which means I can make what? Thromboxane A2. Remember in the last lecture, thromboxane A2 does what? Platelet aggregation. If the platelets can come together and worth it. So I do have normal platelets, which means what's going to happen to my bleeding time? It's going to be high, not because I don't have platelets, it's because the platelets are there, but they're just not working. Right? There's nobody to spread the perfume to attract them to come. I know the reason I can actually have normal platelets and they're not working is this. Uremia. Uremia. Classic. A 40-year-old diabetic patient hasn't gone to dialysis for so long. He can't exceed all those the urea out of their body. The urea actually comes and coats around the platelets. So if you coat the platelets, the antibodies can stick out and stick to each other. So everybody's just playing around and have normal platelets. However, they're not working. They can't stick together. None of those glycoproteins are working at that point. Know that. See how easy this is? So I can actually have low platelets. I'm bleeding a lot, having all these syndromes. Or I can have normal platelets. However, they're not clotting. Now, we can have genetic disorders. There are 3 genetic disorders you have to know. And actually, we're going to go over them. And if you don't remember what I told you, always remember, go back and if you listen to this lecture, always go back to clotting cascade to understand. The first one is Bernard-Soulier. Very rare disease. I don't even think I've seen in my lifetime, which is a glycoprotein 1B deficiency. Glycoprotein 1B, remember, is needed for you to bind to all those von Willebrand. So if there's no glycoprotein 1B, von Willebrand will just be staying there and you're still going to be bleeding. Okay? How do I remember Bernard-Soulier? Bernard start with what? I like this guy. It start with a B. So it's going to be glycoprotein 1B. Remember, I still have normal platelets. The platelets are normal. The problem is they can't bind. Another two is Glanzmann thrombocytopenia. Right? Glanzmann is going to be a deficiency in glycoprotein 2B 3A. That's the same remember that glycoprotein I told you about that needs to cause platelet aggregation? If they're not there, they can produce it. If you have a deficiency, remember, if the platelets cannot come together, you're still going to keep bleeding. You need those two in between the fibrinogen to hold them together. And if they're not there, oops, but look at it. My platelet count is still normal. But what's going to happen bleeding time? It's going to be high because I'm going to keep bleeding because there's no platelet to stick to each other. Another problem could be what? I can have normal platelets, but how about this? Von Willebrand factor is on vacation. This patient is going to come in with mucous membrane. It's classic board question. They're going to tell you it's nosebleeds. They have a petechia. They have a menorrhagia. Right? A 19 or 15-year-old girl is having these problems. Von Willebrand factor. And we're going to talk about the clinical significance and the pathology later, but this is what you got to remember. If there's no von Willebrand, remember those von Willebrand? You need those glycoprotein 1B to bind to von Willebrand. If they're not there, you're going to still bleed. See how easy this is? So if you commit this to memory, so just a brief summary, we're still working on the right side of our brain. Right? Is this superficial bleeding? Think platelet, petechia, ecchymosis, palpable purpura, right? Nosebleeds, menorrhagia. Order CBC stat. Look at the platelet count. Is the platelet count normal or is it low? If it's low, go into this little extra pathway, ITP, TTP, HUS, and HIT. They might be on heparin. Remember, if the patient is on heparin, oh, we got a problem. Or is the patient platelets normal? If it's normal, it's either are they on aspirin. If they're on aspirin, bam, we give you the answer. Are they on dialysis and you haven't had dialysis in a while, they're diabetic, they got uremia. Do they have Bernard-Soulier? Very rare. Glanzmann thrombocytopenia, very rare. Von Willebrand factor deficiency. But what is going to be different about von Willebrand is this. So, this is just von Willebrand, okay? Von Willebrand's disease. What is the platelet count? Normal, right? The platelets are normal, right? What is the bleeding time? It should be high, right? Why? Because there is no platelets to bind to, there's no von Willebrand factor to bind to, remember? However, remember von Willebrand is the husband and factor 8 is the wifey. If von Willebrand is not around, we're going to be missing factor 8. Remember factor 8 is that guy I told you right there that's converting factor 9 into factor 10 in the intrinsic pathway, right? So if there's no factor 8, what would you expect the PTT to be? Elevated. That's why people with von Willebrand factor has high PTT. How about the PT? Will it be normal, abnormal, low, or high? It should be normal. It's PT. Remember, PT is dependent on the extrinsic. We're going to war, right? It's 1972 cofactors. It has nothing to do with this cute little mnemonic I give you, 11 9, 10, 2, 1, right? 7. This is where 8 is and this is where 5 is. This is the guy that's missing. Factor 8. So this guy is going to be PTT is going to be high. So when you order CBC, you should expect platelet count to be normal. However, PTT should be high. They're bleeding because bleeding time, but we don't do bleeding time anymore. But this is a classic board question. This is the way it is, okay? And we are done. It's over. Platelets, platelets, platelets. Let's switch our brains. Let's lock that and go to the left-hand side of our brains. We are going to coagulation factors. This is coagulation factors, not platelets, not platelets. This is coagulation factors, okay? Coagulation factors are the factors I just wrote on the board. These fellas. 12, 11, 9, 10, 2, 1, 7, right? With a little bit of factor 8 and a little bit of factor 5 here. All these bad boys have the coagulation factors. What's the point in life? Their point is to convert fibrinogen into fibrin. Make a nice static plug. If one of these guys is missing, this reaction is not going to happen. It's not going to happen, right? Everybody came to the party except this guy. Forget it. The party's not going to go on. So this is what we're talking about here. How is the patient going to present? The patient's going to come to the hospital, right? They're going to have deep bleed. It's going to be deep in the tissues. I want you to sing along with me. Hematoma, hematorosis, coagulopathy. Hematoma, hematorosis, coagulopathy. Hematoma, hematorosis, coagulopathy. Hematoma, 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 hemathrosis, hemathrosis, hemathrosis. Bleeding in the joints, bleeding in the joint. Hematoma, bleeding in the tissues. Hematoma. It's gonna be on your boards. They're gonna write it there. The guy is bleeding in his joints, right? Any little thing they hit, they're bleeding. They hit, they're bleeding. Why are they bleeding? Hematoma, hematorosis. They just don't throw words around. There's a reason. You hear that word, you're like, coagulopathy, coagulopathy. I'm not a singer, okay? That's not the point. What do you order? I want to order a stat CBC. I'll check the platelets too, because I don't know where it's coming from. But I want to see what that PT and their PTT looks like. So they're going to have patients with easy bleeding. The funny thing is this guy also have easy bleedings because the scratching nose and the bleeding. That menorrhagia the bleeding. But these guys all have easy bleeding. But what makes these guys different is the hematoma, hemathrosis, coagulopathy. So I order a PTT and a PT, and the first thing I think of is going to be like this. The first disease, hemophilia. It doesn't have the word in it. Hemophilia. Hemophilia is a factor 8 deficiency. That means if factor 8 is missing, this guy right here. So let's think about it. Factor 8 is missing. What would the platelet count? Normal. It has nothing to do with platelets. This is platelets. What is bleeding time? It's going to be what? It's going to be high a little bit. Why? Because they're not clotting well. It's actually going to be normal a little bit. But if you touch them, they're going to bleed. What are you going to expect the PTT to be? The PTT, it's going to be high. Because factor 8 is missing. What you think is going to be the PT is going to be normal. Right? So factor 8 is going to cause what? A high PTT. But platelet count is going to be normal. And bleeding time is going to be normal because what will happen is the platelets are going to be able to stick together, right? Except you have von Willebrand missing. The platelets are still going to be able to stick to von Willebrand. They're going to do their thing. But you know what? We can't coagulate. Another disease is what? Hemophilia. This is called hemophilia A. It's hemophilia B. Factor 9 deficiency. We're back to the same story. Factor 9 is missing. We can't feel this, right? And there's also hemophilia C, which is factor 11. Can you see? This is usually in Jews, and it's always males. Don't get that wrong. They will always tell it's a male that's having bleeding in their joints, always bleeding in their arms and their legs. Easy bruising. Every time they jump, bam, they hit something, they're bleeding. Check for factor 8 deficiency. And how do we treat it? Oh, we give them factor 8 back. I like that. We give them factor 8 back. Okay? So, that's the 3 things I want you to first remember. Another thing that you should be worried about is vitamin K deficiency. Right? If somebody doesn't have vitamin K, which I told you is needed to activate factor 1972, 9, 7, 10, 2, right? How can we not have vitamin K? Usually a kid, a newborn baby that's born has no vitamin K in their gut. There's no E. coli. They need E. coli to make vitamin K for us, right? At least we get benefit. They're just not sitting in our poop, not doing anything, right? So we give them vitamin K shot, right? How can we not, if you're not eating enough vitamin K, you're going to be deficient. Also, if you're warfarin, right? If you're warfarin, what will happen is actually, what they don't tell you is, although we always say PT is going to be high, or INR, which is true, because 9, 10, 7, and 2 is missing, but think about it, 9. 9 is on the what? PTT pathway. So PTT is also slightly high. We just don't talk about it. Because it's slightly high, but it's not as high as PT, prothrombin time. Because this is the prothrombin time. Okay? So, but, that's just a little extra information, but the bottom line is PT is going to be prolonged. What about if you're heparin? If you're heparin, you're going to inhibit 12, 11, 9, and 10 by antitropin 3, so obviously PTT is going to be what? Extremely high. Tell me one more thing we need to finish this lecture with to actually understand coagulopathy. Well, I don't even know why we're talking if the guy that actually gives us all this cofactor is not alive. It's like a parent without, a little dog without a father is just roaming aimlessly around, right? There's nobody to provide food for him. If the liver is dead, liver cirrhosis, right? If you listen to the liver function test lecture that I made, you will realize one of the most important things the liver does is what? Make vitamin K and makes all these cofactors except factor 8. So if the liver is gone and it's not working, you're going to be bleeding. You check that PT, very high. Also, you don't have albumin also. But the problem is if you have liver problem, automatically you will actually bleed. This has brought us to the end of this lecture. This is how hematologists think. They make medical students, nursing students, they make them look idiots. But this is how they think. And you're sitting there like, oh my God, I can't figure this out, it's too much stuff. But this is it. Summary. Bleeding disorders, platelets, coagulation factors. Platelets, coagulation factors. Your left and your right and left side of your brain. Okay? Platelet problem, superficial bleed. Okay? Then you have hematoma, ecchymosis, purpura, and you have petechia. Nosebleeds, menorrhagia. Okay? Labs, your other platelet count, is it low? If it's low, think ITP, TTP, HUS, HIT. If they're normal, think they're aspirin, they have uremia, or they have penicillin, glanzman, or von Willebrand. You're done. Switch your brain. Coagulation factors, think hematoma, hematorosis, coagulopathy. Okay? Then you look at the class cascade, which you already memorized, and you start picking and choosing what you want. Hemophilia, factor 8 is out. Okay? It's usually in males. Remember that. Factor 9, factor 9 and factor 11, B and C, okay? Vitamin K deficiency, okay? Think about it. You're not going to have enough vitamin K to make all the cofactors active. PT is high. Liver problems, okay? PTT is still going to be high, okay? And that is it. That's it, guys. I hope you enjoyed this lecture. Please subscribe to my videos and also visit our website, ftpinc.org. Thank you very much for watching. Have a good day. Take it easy. God bless.